Good afternoon, everyone, and welcome to this Grand Rounds presentation. Our speaker is Dr. Amer Burhan. He is the Endowed Chair for Applied Mental Health Research at the Ontario Shore Centre of Mental Health Sciences in Whitby, Ontario, and Associate Professor of Psychiatry at the University of Toronto. He graduated medical school from Baghdad University, then completed a fellowship in neurosciences at McGill, and then came here and did residency in psychiatry at the University of Rochester. This was then followed by advanced training in geriatric psychiatry and neuropsychiatry at Western University in London, Ontario, and he completed a Master of Science in Community Health from the University of Toronto. Amer is the site PI and co-investigator on several pragmatic clinical trials in the area of disease-modifying therapy and neuropsychiatry of Alzheimer's and therapeutic brain interventions for resistant mental illness, in addition to being active in several initiatives to develop guidelines to standardize definitions, assessments and management of cognitive disorders, and treatment-resistant mental illness. He's been very productive scholarly, authored over 75 peer-reviewed papers, been author and co-author on 15 book chapters, and done multiple conference presentations. I do want to add a few personal notes on my behalf as well as on behalf of Yates Conwell. Amer was a part of a fantastic group of residents here at the University of Rochester, and some of his co-residents included Mike Scharf and Tony Villani, all of whom have gone on to do great things. Yates and I dearly wanted him to do his geriatric psychiatry fellowship here, but Canada beckoned, and he has had a wonderful career over there. We've had the great pleasure of watching his career blossom, and I've had the chance to work with him on the interface of geriatric psychiatry and memory disorders. We've done studies together, in particular the escitalopram for agitation in Alzheimer's disease study, where he has taken a leadership role on certain areas of data analysis and publications. I know that I speak for both Yates and I when I say that we couldn't be prouder of him, that we welcome him back to Rochester, even if it is only virtually at this point, and we look forward to a repeat visit when he can be here in person. So Amer, take it away.
Thank you so much, Anton. This is a very kind introduction, and definitely this presentation is very nostalgic to me. I definitely enjoyed my time in Rochester and continue to drive from the mentorship, both from yourself and from Yates, and definitely very proud of my colleagues who have also excelled, as you mentioned. We have leaders in the field, basically with Michael Scharf and Tony Villani and Mona Nikolai, who were my classmates. So appreciate the introduction, and I'll tell you a little bit about my personal journey as I go through this presentation, because that gives things in context. It was already mentioned that I'm now at Ontario Shores. It's really across the Ontario Lake from Rochester. If I had a boat, I probably would have made it faster than driving or flying. Again, this time around, it didn't work out for me to be there in person, but I definitely would love to go back and connect with where my career in psychiatry started. So these are some disclosures that I have. Basically, I am involved in contracting and investigating for industry. I'd also provide advisory board experience, like all of us who are in the interface between academia and creation of knowledge through research. In addition to being peer funded, there's really no specific area of conflict for this presentation that I perceive. This is a little bit about my personal journey. So I have a long journey starting from Syria, where I was born, passing through Pakistan, Morocco, Iraq, Finally, my family settled in Canada, and then, as you know, the circumstances in the Middle East have been difficult and continue to be difficult. So Canada became home for us, and lucky for me, I was able to match psychiatry in Rochester after doing my neuroscience work. And I've been really trying to develop my career through the journey, several universities. I think this is the story in Rochester. I matched in 98. I was among a cohort of excellent residents. I learned a lot from them. I'm mentioning them here again. The director at the time was Dr. Rory Hotalan and then Sudha Giovanni. I did have chief residents that maybe some of you remember, Rida Mirza and Anka Segar. Yates and Jeff Linus, Les Conwell and Jesse Linus have been mentors and preceptors during my residency. And in fact, my first chapter was published with Dr. Yates Conwell. And as you know, Dr. Jeff Linus continued to lead the field and set the standards for both neurology and psychiatry. Dr. Eric Kane was the chair at the time, and I was particularly attracted to Rochester both because of the psychological and psychotherapy heritage, but also neuropsychiatry heritage. As you know, that there was a lot of work being done by Dr. Kane and Dr. Conwell. And then geriatric psychiatry was really, shaped in my mind when I was doing my rotation at the Monroe Community Hospital at the time. Dr. Michael Ryan, Dr. Anton Forstensen, and Pierre Theriault, as you know, who have really led a lot of amazing work. And actually, ECT, my experience in ECT was something that sparked my interest in interventions like TMS and ECT, and our Brewer at the time was the one that was leading that service. So many more people I can mention. I'm sure that I can say that I know for sure that there is several that are continuing to be in Rochester. Maybe not my year, but the year before and after. And Noni Niculescu is one of them that just come to mind, and of course several others who were a year ahead of me. So moving to Canada, I spent some time really doing a lot of development and leadership and in research, and I just arrived to Ontario Shores, and so this is our location in Ontario Shores, across the lake from you, and then the facility is quite nice. I hope that one day we'll have some event where all of you will be invited. We'll get a boat to bring everybody here. So the objective of today's talk is really looking at the clinical relationship between depression, gait speed, and cognition, describe the underlying networks. I'm not going to go in too many details, but really to highlight the fact that there's overlapping network between depression and mood regulation, gait regulation, and cognition. And then appraise the role of depression therapeutics in modifying this relationship. This is one aspect of work, as you heard from Anton, that I do trials in Alzheimer's disease, but I'm really very interested in knowing how behavior and cognition interact as we go through life. So one thing that sparked this field of talking and walking, as you would imagine that as we get older, when we're walking, we tend to have to stop when we're addressing a particularly complex issue. So it's almost like we run out of space and we need to stop walking to focus. So that observation was published years ago by a geriatrician to highlight that there is a relationship between thinking and moving. Of course, that relationship seemed to be age dependent because, as we all know, that the younger the generation, the more they can do it all while they're walking. So they can text and they can interact with others. So there's something about the capacity of our attention and how that impact the resources available to think and walk. So this work actually was highlighted and articulated quite nicely by Dr. Montero Dasso, who's at the Western University, and he's going to be one of the authors on the paper that we're working on from the SCTAD study, looking at falls and mobility in that population that received escitalopram versus placebo. But something to keep in mind that these two syndromes, cognitive syndromes and mobility syndromes, do increase in prevalence and frequency with age. And there's definitely a relationship. We all know this, and we're always concerned about people falling when they develop cognitive disorder. So there is definitely an interaction between the two, and we thought that this might be an opportunity to start addressing this as a risk state. So if somebody is showing gait impairment while they're thinking, walking impairment while they're thinking, then this might be something we have to consider as possible risk state for developing mild cognitive impairment, which is MCI, or dementia eventually. Now, the networks that are involved, as you know, the brain is an incredibly complex set of networks, billions of of connections. So this is a simplistic view of what happens, but we definitely know that executive function, kind of deciding, drawing attention, navigating through information, does address different areas or interact with different areas of the brain, like the lateral prefrontal cortex, and then the posterior cingulate, and then some of those connections go through motivational centers, such as the ventral, anterior cingulate, the nucleus accumbens, and so on. So we know that when you talk about executive function, you talk about frontal subcortical and frontal networks. Now, when it comes to gait regulation, if you look at the left side of the slide, typically people think about the motor cortex and the basal ganglia and going below to the brainstem and the thalamus and so on. But it turns out, obviously, that there's more involved in the regulation of movement and posture, including prefrontal areas and cognitive centers and emotional centers as well. So, you start seeing that overlap, and that leads to the question whether emotions are also involved in this interaction between cognition and mobility. So this the motor cognitive risk syndrome was already articulated as a risk factor for cognitive impairment and dementia. So this is when you have somebody with maybe subjective cognitive change, but you do identify a slow gait as a marker. So if you follow these people who have the motor cognitive risk syndrome, it turned out that higher percentage of them develop mild cognitive impairment and dementia. So at that stage, it was really articulated as only cognitive and motor kind of risk syndrome. And they obviously went ahead and looked at the specific correlates of that, which again overlaps with what I mentioned earlier. And then people start thinking, like, could we utilize this as a way to detect subtle changes in gait speed? So if you have somebody walking and tell them, okay, well, I want you to walk as safely and as fast as you can, and you measure their gait speed using a tool like the gait mat that has sensors and so on. But then you can also add a challenge by asking them to do what they call the dual task. So what do when you ask the person to count backward from 100 by 1 or by 3 or by 7, or get them to perform the Stroop test, for example, where you kind of name the color instead of perceiving it as a color, those seem to enhance the detection of cognitive, motor complex syndrome. So, the question was, and I, this slide is busy, but I'm going to summarize it, that how useful is gait velocity and dual task in predicting cognitive state like mild cognitive impairment? Could you tell? So this is the summary of this, that if you look at gait velocity as a single task, just walking without thinking specifically, you have an effect size of about 0.74. If you add to it a dual task with counting backward by 1, which is relatively low challenge, that effect size increases, meaning that you can detect that state of mild cognitive impairment with the higher effects at 92%. And then, if you add to it more challenge, such as counting by 7, then you actually can enhance that effect size further. So this is a meta-analysis that started giving us, specific, effect size to work with to power our studies as we look at could we modify this syndrome. Now, moving to depression, which is obviously a content expertise of this audience, you've heard it over the years that areas such as the prefrontal cortex and the anterior cingulate and the amygdala and hippocampus, all these things are involved in the regulation of mood. So the question, obviously, like, is there now a relationship between cognition, executive function in particular, mobility, and depression? We know that Alexopoulos, who have articulated a lot of the work in late life depression, have proposed a model where there's a lot of factors that accumulate with age that result in that what they call the vascular late life depression executive syndrome or vascular depression syndrome. So this is something that is already known by geriatric psychiatrists, that sometimes people come to us for depression. The depression seems to be a bit different. You wonder whether they're going to be developing cognitive disorders down the road. So the networks that we speak about when it comes to depression are relatively the same. Like, you talk about the executive network that has the prefrontal area, parietal area. We talk about default mode network when the person is free associating and not particularly thinking about something specific. But then we know that in between these two networks, there's the salient network, where we draw attention to what is emotionally salient to us. So if you look at the state of depression, we know that people have some decrease in their attentional resources, definitely increase in negative perception and decrease in social functioning, and definitely increase in the salient network firing. So it almost drains the attentional resources toward what is perceived as being a negative state or a threatening state. So now that we've had the syndrome that has to do with cognition and motor function, and we're introducing the emotional network into it. So what is the evidence that there's a motor alteration in anxiety and depression? In this systematic review and meta-analysis looked at that and did show that there is definitely detectable motor alteration in clinical sample compared to healthy controls. It's not necessarily different between anxiety and depression, and we all know in psychiatry that the line between depression and anxiety can be quite blurred, especially in old age. I see a lot of people come to our clinic saying that I'm anxious, but you find out that they're actually severely depressed. And I find that syndrome very treatable in old age, although it does affect success of treatment if you use medications alone. So basically, motor intervention were proposed as being one of the things that we have to focus on in this particular meta-analysis. When you look at the psychomotor slowing, which is, again, a concept that psychiatrists know all along, that a person with depression could be very sluggish and slowed down, and some of them will be the opposite, agitated. But it's a complex phenomena that has both motor, cognitive, and subjective component. And this particular study articulated on actual data from the Netherlands, 521 people, that you can break it down, and there's definitely overlap in the middle, but the motor component, the cognitive component. So when you look at what they identified as correlates of these components, that the motor slowing has to do with female age, high number of medication, and higher BMI. Well, the cognitive component of this syndrome, lower global cognitive performance, but subjectively you can see that high level of depressive symptoms is a predictor. So a person will tell you that I feel slowed down, I feel like my mind is slowing down. So I think people are starting to break down this syndrome into its basic components and see what correlates we can learn about. So slow gait in late life depression. So what I mentioned earlier was really depression across the adult lifespan. But when you look at specific late life depression, this is a group of individuals, and this is a study from Germany, the trend study, 401 healthy adults from 50 to 80. Some of them had depressive symptoms, some didn't. And you can see, understandably, that less of the sample has a history of unipolar depression. They followed them for for 6 years, for every 2 years, and looked at their cognitive function, motor function, and so on. They were similar in all aspects, except for significant difference in depressive symptoms that you would expect. So gait speed was inconsistent, but significantly lower gait speed was consistently and significantly lower in depressive samples. So it tells us that this is a marker that could be utilized. When we think about you have a group of mild cognitive impairment and Alzheimer's disease, and you look at the impact of having depressive symptoms, there was no significant association between balance or gait speed. So did not really pan out in this cohort, but this cohort had only mild depressive symptoms. None of them were severe. So we're still left with the question whether we can actually identify the risk group that has the three components, which is cognitive concerns, slow gait, especially with dual task, and depression. Some work was done in Canada. We have the Canadian Longitudinal Study on Aging. This has been going on actually for many years. Probably now it's in the 30 years or so. And it offers us the opportunity to get a large sample of people who are aging, look at all kind of factors. So one of my colleagues in McGill, Dr. Sekhan, worked on looking at what happened if you identify the motor cognitive risk syndrome and then look at the progression of that, or what's the risk of that syndrome of resulting in a cognitive impairment in the future. So there's three age groups: 45 to 54, 55 to 65, and so on. So the motor cognitive risk syndrome was prevalent around 7%. And it seemed to be higher in the younger age group, which is interesting. I mean, we would expect it to be higher in the older age group. But again, this is a community sample. It's not a clinic sample, so might behave differently from what we see in our clinics. Depression increased the odds of having the motor cognitive risk syndrome significantly, like 3.6 odd ratio, regardless of the age group. And the association was across groups, but stronger for younger groups. So it's something to keep in mind that this risk syndrome does not have to wait till age 65. It probably start earlier, and in theory, the toxicity that starts at that age might eventually lead to cognitive disorders in old age. So people are probably quite familiar now with the Lancet Commission looking at modifiable risk factors for dementia. At this point, where the field is claiming 45% potentially modifiable factors. If you look at middle age, depression is represented there, in addition to other factors that are definitely make sense. And then as you get older, more social isolation. I think, really what this highlights that there is an opportunity for prevention in middle age, rather than waiting for late life and start talking about that story. So the question then, does late life depression predict the future development of Alzheimer's disease or vascular dementia? So Breno Dennis did look at this and was able to show that the pooled hazard ratio of all-cause dementia was definitely higher in late-life depression. So 1.8, kind of 80% higher. For Alzheimer's disease, a bit less robust than vascular. So it does correspond to our understanding that frontal subcortical network disruption through vascular lesions and white matter hyperintensity might be more relevant to late-life depression, but again, doesn't take away the importance of it in Alzheimer's disease as well. So it does affect both. So where does this leave us? So depression in midlife versus late life, the question about the onset of depression, like are we talking about the same thing when we talk about depression that have started in the 20s and people have repeated episodes versus those who develop late life depression? And I think people like me and Anton and Yace and others who work in older adults, we know that there's a potential for depression in late life to be a prodrome for dementia, of Alzheimer or vascular. Depression as a risk factor versus early manifestation is something that we have to think about. And then the dysregulation of affect versus loss of motivation. So we need to distinguish between depression as a manifestation versus apathy, which is really the lack of emotional drive, something that we also know is common in Alzheimer's disease and vascular dementia. So, there's something that I think we know now from our colleague, Zainur Ismail, who's now in Calgary, have articulated the potential for us to start seeing mild behavioral impairment in people in their 50s as an early manifestation of cognitive disorder. So he clustered it very nicely into change in behavior and personality that has to do with affective regulation, or apathy, which is the lack of motivation or impulse control issue, socially inappropriate behavior, and so on. And then you have the more issues with, function and inability to deal with the interpersonal relationships and so on. So I think, this is a nice way to start looking at the potential for us to identify these symptoms much earlier than we typically do now, which is really waiting for it to manifest itself as an illness. So predicting dementia from the mild behavioral impairment has now been looked at. This is from the ADNI, which is the Alzheimer's Disease Neuroimaging Initiative. It does show that impaired drive could be a predictor, emotional dysregulation could be a predictor, impulse control. So, we do have now tools that are now validated to start showing the potential for us to predict future dementia. I think the overlap between these two is important to highlight, that while we talk about depression as being depressed mood, hopeless, feeling guilty, having thoughts of suicide, apathy is kind of more the lack of emotion, so lack of motivation, initiation, indifference. But in between, I mean, they can overlap enough to make it difficult to distinguish. So that's something that we have to consider. Now, apathy as a syndrome of lack of motivation or low motivation without necessarily having negative affect has been looked at in when it comes to gait and executive impairment. So there's a triad that was described, aged triad, in vascular variant of cognitive disorder that showed that people do have the syndrome of apathy, mobility issue, and cognitive impairment. We started thinking about, well, what about late life depression? So there was an opportunity we had. We were studying people with late life depression, and we had gait information about them, and we compared them to people with mild cognitive impairment or normal cognition. And what we have found that the while mild cognitive impairment clearly different from normal control, having difficulty with the dual task, the late life depression without cognitive disorder fit in between. So it does tell us that maybe it's an earlier manifestation, at least in some people, before developing cognitive impairment. So we started thinking about gait and dual task cost, which you can see it in the lower line here, that we definitely want to see if this become a useful marker to predict cognitive challenges in late life depression. So we started talking about something called the triad of basically thinking, feeling, and walking, the title of this talk. The triad in late life depression, we looked at it. We did a scoping review or systematic review, and we had 15 studies, including about 11,200 participants, 4 longitudinal study with at least 368 participants. And then 12 out of these 15 studies reported the presence of this triad of depression, slow gait, and executive dysfunction. The percentage is about 17% prevalent in the larger population studies. And then they seem to be related or linked at least to vascular risk factors and white matter hyperintensities. And there were some interventional studies that started showing some promise, like one pharmacological cholinesterase inhibitor at the time, and 2 exercise studies. But the results are still mixed because they were not particularly powering the studies to detect the difference using the triad that we're articulating. So this triad seemed to, be reasonably well received. People have wrote about this, that it could be a measurable triad, but also, of course, there's caution that these syndromes do overlap, and we have to continue to try to clarify the relationship between the three components without necessarily making assumption that is going to be present in everybody. But there's definitely a question about is this a detection of a neurodegenerative illness very early on, which is definitely a predominant hypothesis, or is it a risk state, like meaning that if you have depression, you set yourself for future development of cognitive disorder rather than being part of that early manifestation of that disorder. Now, the Silva, this is a Brazilian study that looks at cross-sectional data from a trial, 609 community-dwelling individuals. They started looking at the antidepressant effect. I mean, the reason why I'm talking about antidepressant, obviously, because we do treat late-life depression with antidepressants. So the question whether is that a good good strategy, or do we have to worry about the effect of antidepressants on fall? So in this study, they did see that antidepressant had significant basically moderating effect between depressive symptoms and recurrent falls. And this is actually what we're going to be looking at in the study that Anton mentioned. The acetate study was the escitalopram for agitation study led by Anton and Kostas Laketsos from Hopkins. We were part of the study. And some of the news in that study, one, that it didn't really help agitation as much as we were expecting, but also that there's QT interval prolongation and increased falls, while no significant difference on MMSC. Now, we will be looking at the falls specifically, and the paper is now being circulated to look at what do we understand from the risk of falls with escitalopram. So, I think it's important for us to recognize that there's an issue with falls and gait with depression and cognition that I articulated earlier, but also that what we use to treat depression could be a factor in increasing the risk of instability and falls. So that leads to other options. So what do we do if antidepressant may not be the best option? I mean, I'm not advocating at all that you don't treat people with antidepressant. I'm just saying that it's a factor to consider. And I have been really interested and involved in looking at transcranial magnetic stimulation to see if we can offer cognitive enhancement and while we're treating depression. This is an example of the meta-analysis, network meta-analysis, looking at the effect of RTMS, transcranial magnetic stimulation, for mild cognitive impairment and Alzheimer's disease. And it does show that it has an effect size on cognition. I think maybe the easiest is to look at the high frequency, for general cognition, it has an effect size of 1.24, but right dorsolateral prefrontal cortex low frequency has even a higher effect size of 1.5. So there's a promise from it, but we still need to be more precise and find a better targeting and better understanding of what part of the network we need to target. This is showing you that using RTMS actually changes the plasticity of the brain. And that could be seen in the EEG recording, but also in the something we call theta gamma coupling, which is the change in the excitability. So there's definitely evidence that what we do with RTMS translate to neuroplastic effect. We have actually published years ago about facilitating gait with prefrontal RTMS in multiple sclerosis, like somebody has significant white matter hyperintensities, and we did show that the gait has improved. It wasn't long lasting, but it is like even after one session. But what about repeated sessions? That'll be an interesting question to have. So this is a recent publication from our group looking at cognitive and gait effect of repetitive transcranial magnetic stimulation in mid and late life. And we did show that RTMS improved memory and inhibitory control in older adults with depression. Gait speed increased with high frequency RTMS in mobility impaired participants. And there's some domain specific tools that detect the RTMS effect, but it is missed in kind of global scale. So basically, if you go to specific domains like executive function, fluency and so on, you might be able to detect it, but in a global test, you may miss that opportunity. We did not see increase in seizures or death or adverse events. The adverse events were quite mild and self-limiting. So it's a promising tool, and it does support that rTMS might be safe, and adds to the repertoire of tools we have to treat late life depression. Our colleague, Dr. Raji and his group did look at the effect of other forms of brain stimulation, which is really they call it TDCS, with transcranial direct current stimulation, that shows that in JAMA Psychiatry published recently, showing that actually there is a large effect size of improving cognitive function and stabilizing the course, particularly in those with late life major depressive disorder, even better than mild cognitive impairment. So it tells you that there might be an opportunity to address that phenotype before it become an illness. But this is my fellow Adrian Espirito, who's now back in the Philippines, who designed the study that I'm going to mention now, which is trying to modify dual task with brain stimulation. We did look at the pilot data we conducted with high frequency. The data were being analyzed, but so far I've not seen a robust effect from using high frequency. So we're exploring theta burst stimulation because it's known to be more efficient in inducing neuroplasticity. So there's a study that we're conducting now called Cognitrid study that recruit people with late life depression, kind of more above the age of 50, and looking at gait and cognitive correlates. This is the paradigm that we're going to be using. We've used it in depression. It kind of goes to the right side of the brain and delivers on the F4 area, which is correspond to the superior frontal gyrus, delivers inhibitory paradigm, continuous theta burst, and then you go to the left side and excite. So it's really try to shift the excitability back to the left cortex, which is more friendly for executive functioning. So in summary, the dual task gait parameters can be a sensitive and feasible way to detect cognitive status and predict cognitive decline in older adults. So we have now established that this is something that we can continue to pursue as a marker of even pre-MCI. So even before the person's develop the earliest detectable, so subjective cognitive impairment would be a good target for this. Late life depression is at high risk of all-cause dementia, including vascular and Alzheimer. But we know from what I mentioned that the vascular dementia stories seem to be even more relevant. There's evidence that dual task cost in gait is intermediate in late life depression between normal cognition and MCI. So again, it just confirms the idea that we could be identifying a cohort earlier than MCI. We did demonstrate that there's a triad of depression, executive dysfunction, and slowed gait. This triad is clinically meaningful, and I think we need to identify ways to operationalize it and offer treatment for it. And just to be clear, that I'm not suggesting that this could not be treated with exercise, for example, because I mean, rTMS is a good option to treat depression, but we all know that physical activation can be an answer, except it's not adequate when somebody has severe depression resistant to treatment. So, we consider it as a definitely important adjunct treatment to provide. And then, affective regulation versus affective deficit is important to consider, because we know that apathy is kind of syndrome of affective deficit is a very important and very disabling and impactful on caregivers. So we are dealing with now trying to refine this clearly. The International Psychogeriatric Association have assembled working groups, including a lot of people from different centers, including, of course, the US and Canada and other jurisdictions, to try to reach consensus on how to define apathy versus depression and cognitive disorders, and what are the interventions that are available. And then I hope that I kind of provided some excitement about the possibility that brain stimulation is potentially a good neuroplastic intervention for depression and executive dysfunction and gait triad, because we think that the illness is a neuroplasticity illness, and these tools are a more direct way to adjust neuroplasticity. So it's from the concern that we have about antidepressant, including the very considered safe SSRIs like escitalopram, are associated with change in gait, which kind of create a concern about the possibility of adding insult to injury when it comes to gait dysregulation. So I think I left enough time for a lot of questions, and I hope that we'll engage in dialogue about what this means to you and what are some of the areas that you want me to clarify further. Thank you so much for listening.
Are there any questions? The microphones are on, so you guys can just speak up if you want.
I do. Yeah,
So she's yes, 1 second.
Yeah. I also do see a question from Dr. Conwell in the chat. I'll prepare to answer as well.
Great.
Awesome.
Thank you so much. You can go ahead and start with Dr. Conwell's question. I can see that as well, and then I'll work backwards to the other one after you've concluded then.
So, yeah, I think the question from Dr. Conwell.
Maybe I can read the question first.
Yeah, please. Yeah.
First, he starts with thanks, which is very important. It's an example of how astute clinical observation leads to important questions for study. Question: 1 in 4 older adults fall each year. It happens a lot and costs something like $80 billion for non-fatal falls annually. Some who fall, but not all, develop a disabling fear of falling again, an important independent treatment target. Separate from the dual task performance measures, have you looked at fear of falling as a correlate of the syndrome as well, and a treatment target?
Right. Yeah, great question. Thanks again for the compliment. I think, as you know, again, the interest in geriatric psychiatry came from your mentorship as well, Dr. Conwell. So I appreciate. So yeah, I mean, I think I've seen it like a lot of us in geriatric psychiatry. Fear of falling is it's almost like an intense insight by the person who have fallen that they could fall again. And I think one of those questions would be, do you treat this with medications and then add to the risk of falling, or do you actually try to provide a framework of safety in a way? So my approach has been usually making sure that the person have all the tools they need to prevent fall through occupational therapy assessment. But you're absolutely right in terms of does that. I view it as part of the subjective cognitive impairment spectrum. Like people actually do have something that they feel that we don't see, and they will tell us, basically, that's their cry for help. They tell us that, I don't know if I want to walk because I'm going to fall again. Or so for me, it's an invitation to do. Now, I like the idea of actually identifying. We have collected data in some of the studies that we're currently conducting on anxiety. It's not specific to fear of falling anxiety, but anxiety symptoms is something that I'm going to be looking at. In fact, we're analyzing data from the gait and brain study and the synergic study that we conducted with Dr. Montero Odaso to look at whether anxiety and depressive symptoms are in fact influential on this syndrome. But very good question, and definitely I'll be considering following up on that.
Terrific, thank you. We do have a few more questions in the chat, but is there anyone else in the room who might have a question live?
Okay. The next one says, given that
Late life depression is often characterized by executive dysfunction, fronto-subcortical disconnection, and psychomotor slowing, do you see a role for accelerated TMS protocols such as SAINT once safety data exist in addressing the network insufficiency that underlies this subtype of depression?
Yeah, great question. I think as those would know that the SAINT protocol is an attempt to bring TMS into a bit more feasible application. So you actually deliver in 1 week what you would deliver over 6 weeks, right? So if you want to do 30 sessions daily, it's going to take you about 6 weeks, unless you want to work over the weekend, which hopefully some of you don't want to do that to enjoy your family. But yeah, the SAINT protocol has 2 components: the accelerated component, which is giving the session every hour, and a precision component, which is targeting based on an fMRI. Now, I'm glad you asked this question, because this study that I mentioned, the Cognizate study, started as planned to do over 6 weeks. But because of the difficulty recruiting people who didn't want to wait for 6 weeks, we actually moved it to accelerated, because we have just done an accelerated study with intermittent theta burst, and it was equivalent to 6 weeks in terms of efficacy for depression. So this study, the Cognizate study that I mentioned, will be actually bilateral sequential accelerated. I should have said that. I think the slides were from when we were planning to do it on so I'll be reporting on this study when it's done, but it is going to be definitely 5 days, 6 sessions a day for a total of 30 days. And we will be collecting, of course, gait and cognitive and biomarkers as well, including EEG. So very good question, and the answer hopefully will come. SAINT protocol, like in the States, obviously it's kind of approved. In Canada, we have a bit of a less regulation when it comes to TMS. So we're using bilateral theta burst. It's feasible. You don't have to have a fMRI. We use correlates on the brain. But it is accelerated.
For anyone who doesn't enjoy spending time with family, you're welcome to work on weekends, or we have a family therapy service in the department, so just keep us posted.
I remember that service. I learned a great deal. I continue to use it in every interaction I have with family. So
excellent,
amazing.
Excellent. The next question is, has there been any finding indicating that cognitive remediation treatment can be helpful to assess the triad?
Very good question. I think the study that I cited from Dr. Raji and his team from CAMH, they did actually TDCS, which is transcranial direct current stimulation plus cognitive remediation. So basically what they did, everybody got cognitive remediation, and they added TDCS to see if it will accelerate or increase the effect size of the intervention. And they did show that this actually helped people stay cognitively well longer and improve their cognitive function. It wasn't specific to the triad, which is actually, so I'm aware that the study that we're doing, the Cognizate, will be probably the first one that looks at the gait and cognition and depression at the same time. But that's the closest I can think of is the TDCS study published in JAMA Psychiatry. So you can, Raji and his group have it. So, but definitely one thing that I want to mention, that cognitive engagement, and in fact, we just looking at, it's under review, a paper on cognitive behavioral therapy and magnetic stimulation or electric stimulation, because we think that these interventions are working with the same network. So if you prepare the network, so let's say somebody is going for a course of cognitive behavioral therapy or cognitive remediation, if you actually prepare the network by giving it the best chance to receive the intervention, you're probably going to have a synergistic effect, but it's something that we need to prove experimentally.
Terrific. Thank you. This is an interesting question, especially for so many of us that work in integrated settings or work with people with a lot of medical comorbidities. When working with an older person who has a physical condition that affects gait, like a joint replacement or arthritis, can your insights still be applied to understand their treatment needs and their depression?
Yeah, I mean, it's one of the important things to consider that if somebody at particular risk of falls, I mean, I view it a little bit differently when it comes to like if it is a specific injury, like let's say a right hip replacement, and I mean there's different rules when it comes to rehabilitation target, but definitely in frailty, like somebody who's frail and have an overall risk of falling. I think what the data from the SCTAD that I presented and hopefully will articulate and publish will tell us to be cautious about using antidepressants when there is a gait abnormality. You just have to weigh the risk and benefit the way you would have done with antipsychotics. We don't know the mechanism yet, but it seems to be there's some kind of acceleration of movement or some kind of jitteriness of movement or reduction in coordination. But it is something that we consider. Now, the only problem, of course, that not treating is not an option, because we know that if somebody sustained a stroke and did not get treated for depression, their mortality is higher, their recovery will be less optimum. So I think it's balancing the risk and benefit. I always leverage, in an interdisciplinary team, leverage the expertise of occupational therapists and physiotherapists, who usually tell me that, this person is particularly at risk of falling. Make sure that before you give them this drug, that they have now comfort using a walker or making sure that they're. So I definitely live with falls every day. It's part of our metrics that we monitor over time. So the question is definitely relevant to all of our practices.
Yes, thank you. The penultimate question, have other antidepressants been tested? And if so, what are the findings?
So antidepressants, when it comes to agitation in particular, or because I know, the study that I mentioned with escitalopram, which is one antidepressant. Previously, we had citalopram, which Anton was the first author on, which is a successful trial for citalopram for agitation, for example. And I think the target from the escitat was to utilize something supposed to be more clean, or kind of uses only one copy of the isomer of the molecule. Anton can speak to this much more elegantly, but in reality, citalopram was positive, escitalopram was not. So we just still don't know. Now, I did see some case studies and case series for sertraline for agitation. But when it comes to depression, obviously, the whole set of antidepressant has been studied. There's less specific studies for seniors when it comes to trials. So we always extrapolate from the studies in adults that included seniors. I know that duloxetine has trials that included seniors. So in general, we consider these treatments more senior friendly if they're less contaminated by anticholinergic side effects or sedating side effects. But in reality, this was a surprise to us that even the cleanest SSRI that we considered increased the risk of fall. But it's in this population, just to be clear. We're not talking about depression, late life, or mild cognitive impairment. This is people with Alzheimer's disease, moderate to advanced, with agitation.
Yes, thank you. And our last question comes from Dr. Van Orden. Such an exciting talk. I lead a research lab on loneliness and suicide in later life, and got excited thinking about the role of loneliness or social isolation in your triad, and was wondering if you have thoughts about where social connection fits in and the potential role for social exercise groups to impact depression and cognitive decline. I love that. Yeah,
wonderful question. I think it kind of gives me a chance to invite us to collaborate on this, because some of those in geriatric psychiatry would know Dr. Dilip Jesti, who's the editor-in-chief for International Psychogeriatrics. So we are actually, even yesterday, we had a discussion with him about loneliness and how can we treat and support loneliness as a modifying risk factors in Alzheimer's disease. As you can see from my earlier slide on the modifiable risk factor, loneliness and social isolation in late life is a predictor of developing Alzheimer's disease. The problem with the concept of loneliness that people sometimes mix it up in terms of social connection versus loneliness. One of the things that Dilip just told me that, well, I can be quite content with my, having a relationship with my spiritual being or being by myself. And you see people with 10, 20 relationship and they're not feeling connected, right? So it's really a concept that we are very interested in studying, and I'll be happy to connect to discuss what we're trying to do there, because we're leveraging AI and quantum AI to try to understand the biological correlates of loneliness, like try to understand what does it look like for a person who is lonely and feel lonely, even among hundreds of people. Is that like not all of them actually are depressed. Some of them will say, I'm not depressed, I just feel lonely, I feel isolated. And we still don't understand that phenomena, yet it is an epidemic, and it's very important predictor of all kind of health, negative health outcome, including Alzheimer's disease. So now, in this context, I have not specifically looked at it. We did not have the specific data to look at it. But moving forward, we are looking at defining loneliness as a construct and try to identify a phenotype that will allow us to start thinking about interventions. So could the interventions be, oh, sorry about, they're testing something in Canada. So here we go. Let me mute my.
We couldn't hear it, but it sounds like a collaboration with Dr. Van Orden and her team actually would be quite advantageous based on what they've learned about loneliness.
Absolutely. I mean, I'm always, obviously Anton and I had the privilege to work with Anton in the SIDAT trial, but I want to connect back with my academic roots in Rochester, and loneliness is the coming frontier, especially with the tools we have looking at how people fare in physiologically. We have biomarkers to look at. We have, physiological markers. So I do believe that this is an area that need to be addressed, and it's, we're the best to address it because we have understanding of the psychology and biology of humans.
Excellent. Thank you so much. We're basically neighbors, so a collaboration should be no big deal.
Yeah, I'll tell you, that ferry did not work out, but we might be able to initiate a University of Toronto, University of Rochester ferry to bring that collaboration.
I'm pretty sure we'd only want it to go one way, but I'm not really sure. Any other questions here in the room? And if not, I will say on behalf of our department, thank you so much for being with us and sharing your expertise. I know you're going to get to spend some time with our residents after this session. We'll give you a little bit of a break. And I just want to say thank you so much and have a great afternoon.
Yeah, I appreciate the invitation. This has been a great pleasure. I know I'm going to make it to Rochester soon, but this was a nice way to actually get started at least.
Thank you.
Yeah, appreciate it.
Thank you so much.